Hello, it's me again, Dr. Gulala, giving you the second lecture in the membrane and receptor module, and it is about the pharmacology of the autonomic nervous system. In this lecture, I would explain how do drugs affect the autonomic nervous system. And in order to make it easier, it is classified into four major groups. The first class are those drugs that increase or stimulate the sympathetic nervous system response. The second class are those drugs that increase the parasympathetic nervous system response. The third one are those drugs that block the sympathetic, and the last group are those drugs that block the parasympathetic. So we have sympathetic stimulator, parasympathetic stimulator, sympathetic blocker, and parasympathetic blockers. First, we will start with the first group of drugs, which are the sympathomimetic. It is called sympathomimetic because they are producing an action similar or mimic that of the sympathetic nervous system. Also, it is called adrenergic agonist because they are agonist at the adrenergic receptors. Regarding the classification of adrenergic agonist, this classification is based on the mode of action. We have direct acting, indirect, and mixed one. The direct acting, from its name, it is going to stimulate the receptor directly, so it will directly stimulate the adrenergic receptors. The indirect acting sympathomimetic, they have nothing to do with the receptor, but it will stimulate the release of noradrenaline from the nerve terminal. For example, we have amphetamine. Mixed one, from its name, it's going to stimulate the receptor and also stimulate the release of noradrenaline from the nerve terminal. Example, we have ephedrine and pseudoephedrine. We will start with the direct acting or direct stimulation of the adrenergic receptor. This is also subclassified according to their affinities to the receptor. For example, we have non-selective and selective. What we mean by non-selective? We mean by non-selective direct acting sympathomimetic are those drugs that are going to stimulate all the adrenergic receptors, both alpha and beta. We have adrenaline, noradrenaline, dopamine, and isoproterenol. These four are also called catecholamine due to the presence of catechol ring in their structure. The important character of these catecholamine, they are very potent, but they have a very short duration of action. Why? Because they are rapidly metabolized or break down by two enzymes, which is called COMT or catechol or methyltransferase and MAO monoamino oxidase. Another feature, they are polar, so they do not penetrate the blood-brain barrier. So very potent, easily break down by these two enzymes with short duration of action and do not penetrate the blood-brain barrier. For example, if we take adrenaline, it is one of the catecholamine, non-selective sympathomimetic. It will stimulate both alpha and beta receptor. Usually the circulating adrenaline has more affinity to beta receptor, but when the dose is increased, it is going to stimulate alpha more. It has so many clinical applications. For example, it is the drug of choice in the treatment of anaphylactic shock. Usually it is given subcutaneously, and it can be injected intracardiacally in case of cardiac arrest, and also sometimes it is mixed with the local anesthetic during minor operation in order to increase the duration of local anesthesia. Why? Because of the vasoconstriction. While noradrenaline or norepinephrine, it is another catecholamine, non-selective, sympathomimetic. The important feature about the noradrenaline is that it is highly selective, or it has higher affinity to alpha 1. It will cause extensive stimulation of alpha 1 receptor and cause extensive vasoconstriction and increase in the blood pressure. Theoretically, we can get benefit from this feature, for example, to raise up the blood pressure in case of hypotension. But practically, it's not applied. Why? Because if we give noradrenaline subcutaneously, it is going to cause the sloughing or necrosis of the tissue. Secondly, because of this extensive vasoconstriction, it will decrease the renal perfusion. That is why it is not applicable in the treatment of shock or hypotension. Dopamine, another catecholamine, non-selective, sympathomimetic. It is the precursor of noradrenaline. It is going to stimulate both alpha and beta. In addition to alpha and beta, it is also stimulate the dopaminergic receptor in the renal vasculature. So by stimulation of dopaminergic receptor, it will cause vasodilatation and increase renal perfusion. Through the stimulation of alpha, it is going to raise up the blood pressure. Through the stimulation of beta receptor, it is going to increase the force of contraction. These features make dopamine the drug of choice in the treatment of shock. Isoproterenol, another catecholamine, non-selective, but it has higher affinity for beta receptor, both beta 1 and beta 2 receptor. So these are the non-selective direct acting sympathomimetic. What about the selective sympathomimetic? We have selective alpha agonist and selective beta agonist. For example, in the alpha 1 agonist, we knew before that alpha 1 mainly present in the peripheral vasculature, in which stimulation of alpha 1 cause or induce vasoconstriction, increase resistance, and increase in the blood pressure. So methoxamine, it is synthetic derivative of noradrenaline used as a pressor agent, especially after spinal injury to treat hypotension. We have also xylometazoline. It is mainly given topically as a nasal drop or nasal spray to treat nasal congestion through vasoconstriction of the nasal vasculature. Phenylephrine, also it is present as a topical eye drop to produce mydriasis or dilatation of pupil before ophthalmological examination. So these are alpha 1 receptors agonists. Regarding the alpha 2 agonist, we mentioned before that alpha 2 present mainly as a presynaptic neuron receptor. Its action is to inhibit further release of noradrenaline. We mean by that it acts like a negative feedback mechanism. Clonidine and methyl-dopa, both of them are alpha 2 receptor agonists. Both of them used in the treatment of hypertension, especially hypertension during pregnancy. The mechanism is that it is going to stimulate alpha 2 and it is going to inhibit the sympathetic outdrive by inhibiting noradrenaline release into the synaptic space. What about the beta? We have beta 1 agonist and beta 2 agonist. Regarding beta 1, we mentioned before that beta 1 it is mainly present in the heart, in which stimulation of beta 1 will increase the force of contraction. So dobutamine is a selective beta 1 receptor agonist. It is used mainly in the treatment of acute heart failure. Dopamine, I just explained the dopamine that affect both alpha, beta, and dopaminergic receptors. Regarding beta 2 receptor agonist, we have metaproterenol, albuterol, salmeterol, terbutaline. These all are selective beta 2 receptor agonists. We mentioned before in the previous lecture, the most important feature of beta 2 function is what is the bronchodilation. So we can get benefit from this feature in the treatment of what? In the treatment of asthma and chronic obstructive pulmonary disease. But we should be aware when we use this drug, because the cardiac effect observed at high dose, we mean by that the selectivity is only at low dose. When the dose is increased, the selectivity will be lost. You should be aware when we use this drug in patients with cardiac problem. Okay, that was about the direct acting sympathomimetic. We come to the indirect acting sympathomimetic. As I mentioned, this group of drugs, they have nothing to do with the receptor. They are going to stimulate the release of noradrenaline from the nerve terminal. For example, we have amphetamine. Amphetamine is one of the CNS stimulant. It is indirect acting sympathomimetic. How it acts? It's going to increase a release of noradrenaline into the synaptic space via a reverse action of plasma membrane transporter. So it's going to increase the amount of noradrenaline in the synaptic space. By this, it will induce more sympathetic stimulation. It can be used in the treatment of attention deficit hyperactive disorder, and also can be used in the treatment of obesity. Another indirect acting sympathomimetic, we have cocaine and antidepressant. The mechanism of these two, they are going to block the reuptake of noradrenaline into the nerve terminal. By this, they are going to increase the amount of noradrenaline in the synaptic space and more sympathetic stimulation. From their name, cocaine, it is one of the narcotic analgesia, antidepressant used in the treatment of depression. The last indirect acting sympathomimetic are MAO inhibitors. I just mentioned before that one of the enzymes responsible for the breakdown of noradrenaline was MAO, monoamino oxidase. So what happens if we block this enzyme? We are going to increase the amount of noradrenaline. By this, we are going to increase the activity of the sympathetic. By this, we have done with the first group of the drugs, which was the sympathomimetic. The second group of drugs affecting the autonomic nervous system is called sympatholytic or adrenergic antagonists. These groups are acting by a blockage of the adrenergic receptor. It's also called sympathetic blocker. Also, it is classified according to their affinity to the receptors. So we have alpha blockers and beta blockers. First, we will start with the alpha blockers. In the alpha blockers, we have, for example, phenoxybenzamine and phentolamine. Both of them are non-selective alpha blocker. We mean by that they are going to block both alpha 1 and alpha 2. Both of them used in the treatment of pheochromocytoma. What is pheochromocytoma? It's a catecholamine secreting tumor causing hypertension. The only difference between phenoxybenzamine and phentolamine is that phenoxybenzamine has long duration of action because it is going to block these two receptors irreversibly, while phentolamine, it is a competitive blocker. What about the selective alpha blocker, for example, prazosin, tirazosin, doxazosin? These three are selective alpha 1 blocker. They are used in the treatment of hypertension. The mechanism is that we said that alpha 1, it is mainly present at the peripheral vasculature. Stimulation will cause vasoconstriction, increase resistance, and increase the blood pressure. So what happens if we block these alpha 1 receptors? We are going to induce vasodilatation, decreasing resistance and decreasing blood pressure. That is why they are mainly used in the treatment of hypertension. Tamsulosin, it is used for the symptomatic relief in patients with benign prostatic hypertrophy because it is going to relax the prostatic urethra. Yohambine, it is selective alpha 2 blocker. It is mainly used as a sexual stimulant. What about the side effects of alpha 1 receptor antagonist? The most important side effect associated with alpha 1 blocker is postural hypotension with reflex tachycardia. Why postural hypotension? Because of the vasodilatation and pooling of the blood at the lower limb especially. So the patient becomes unable to stand up suddenly and might get, for example, syncope, especially at the first dose. That is why in order to prevent this first dose syncope, it is better to give 1/3 of the dose and at the bedtime. And the tachycardia is occur as a reflex tachycardia due to hypotension or decrease in the blood pressure. What about the beta blockers? It's also subclassified according to the selectivity. We have non-selective beta blockers and selective beta 1 blockers. In the non-selective, we have the following. For example, we have propranolol, nadolol, timolol, etc. In the selective beta 1 blocker, we have atenolol, metoprolol, acebutolol. We have also non-selective both alpha and beta blocker. For example, we have labetalol, carvedilol. Labetalol, it is non-selective alpha and beta blocker, mainly used in the emergency lowering of the blood pressure. Carvedilol, it is used in the treatment of congestive heart failure. If you notice, we can see that it is written in the pindolol and acebutolol, they have intrinsic sympathomimetic activity. What we mean by ISA? We mean by that these two drugs are not pure beta blocker. They are going to stimulate the beta receptor weakly in order to prevent the binding of more potent endogenous noradrenaline. That is why they are partial agonists. And this is helpful to decrease the side effect associated with beta blockers. We have also nabivolol. In addition to its blocking effect on the beta-1 receptor, it has also vasodilatory effect because it is going to increase nitric oxide release. Regarding the clinical indications of beta blockers, first, it is used in the treatment of angina pectoris. The mechanism, it is going to decrease the workload of the heart. The second clinical indication, it can be used in the treatment of cardiac arrhythmia. For example, beta blockers can be used to treat stress or exercise-induced tachycardia. This is first. Secondly, some of the ectopic are adrenergic dependent. So by blocking the adrenergic, we are going to decrease the chance of ectopic. In the treatment of congestive heart failure, especially carvedilol, as I mentioned before, and metoprolol, both of them used to treat congestive heart failure, not acute, congestive chronic heart failure. And the treatment should be under supervision, and usually we start with a small dose in order to prevent decompensation of heart failure. Other clinical indication, it is used in the treatment of glaucoma. What's glaucoma? It's a condition characterized by increased intraocular pressure, either due to excessive production or decreased drainage. Beta blocker is going to decrease the production of aqueous humor from the ciliary epithelium. So it can be used to decrease or lowering the intraocular pressure. Other clinical indication, hypertension. The mechanism, by blocking beta-1 receptor, we are going to decrease force of contraction and rate, and we are going to decrease cardiac output, so decreasing the blood pressure. Another mechanism is that by blocking the beta-1 receptor, we are going to decrease the stimulation of renin-angiotensin system. Another clinical indication, beta blockers can be used in the treatment of myocardial infarction. Beta blockers is used after myocardial infarction because it will decrease mortality. It will improve survival in patients with myocardial infarction. Why? Because it is going to decrease the sympathetic overstimulation, decrease remodeling, or decrease fibrosis, which are responsible for sudden death of different type of arrhythmia. And lastly, it is the antidote of theophylline poisoning. So these are the clinical indications of beta blockers. What about the side effects of beta blockers? The most important side effect associated with beta blockers is bronchoconstriction, especially with the non-selective one. So it's contraindicated to give beta blocker to patients with asthma or COPD. Heart failure, hypotension, bradycardia, the patient become unable to do his or her exercise because of the decrease in the cardiac output, reduced peripheral blood flow due to decrease in the cardiac output, and also when we are blocking the beta receptor, the alpha remain unopposed and might cause vasoconstriction. Hypoglycemia because of the blockage of beta 2, and it's better not to give beta blocker to patient with diabetes because we are going to mask the warning sign of hypoglycemia and the patient might slip to coma. Sexual disturbance, bad dreams, and withdrawal syndrome. I will talk about this later. We have also centrally acting sympathetic blockers. This is not very important because I never heard about these two drugs in the clinical practice, but we should know something about them. For example, reserpine and guanethidine. Both of them are centrally acting sympathetic blocker. Reserpine will act by decreasing the storage of noradrenaline, while guanethidine will reduce the release of noradrenaline. Both of them can be used in the treatment of hypertension. Okay, by this we have done with the second group, or the sympathetic blockers. We will come to the third group of drugs that affect the autonomic nervous system, and this group are called parasympathomimetic. From its name, parasympathomimetic, this group of drug will stimulate the parasympathetic nervous system, or they are going to produce an action similar to the parasympathetic stimulation. It is also called cholinergic agonist, muscarinic agonist, or parasympathomimetics. Let us remind ourselves what was the function or action of the parasympathetic. It was preparing our body for rest and digest. So parasympathetic stimulation will produce secretion everywhere. For example, salivation, lacrimation. It will induce contraction of the bladder muscle, increase peristalsis, diarrhea, and induce vomiting. How these actions occur? By the parasympathetic neurotransmitter, which is called acetylcholine. Regarding the classification of parasympathomimetic or cholinergic agonist, it's also classified into direct and indirect. The direct acting cholinergic agonist, from its name, bind to the cholinergic receptor and activating them, while the indirect acting cholinergic agonist, they have nothing to do with the cholinergic receptor, but they are going to increase the amount of acetylcholine in the synaptic space. How? By decreasing its breakdown. How? By inhibiting the choline esterase enzyme. We will start with the direct acting. In the direct acting, we have acetylcholine, carbachol, pilocarpine, and betanicol. Acetylcholine is the prototype of cholinergic agonist. It is the neurotransmitter of the parasympathetic nervous system. It is non-selective. We mean by that it is going to stimulate both muscarinic and nicotinic receptors everywhere, and it is sensitive to choline esterase enzyme. Because of this feature, it has an ultra short duration of action. That is why it is not given systemically, but topically it can be used during surgery to produce meiosis or constriction of the pupil. Carbachol synthetic derivative of acetylcholine, also non-selective, but resist the action of choline esterase. Also given topically as an eye drop to produce meiosis during surgery, and also can be used in the treatment of glaucoma. Pilocarpine, which is the most important cholinergic agonist. It is tertiary amine. We mean by tertiary amine, it is non-polar, it's lipid soluble, it will distribute everywhere. It is selective muscarinic agonist, resist the action of choline esterase enzyme, and it is the drug of choice for the treatment of glaucoma. How? The mechanism, it is going to increase the drainage of aqueous humor. If you remember, the beta blocker was acting by decreasing secretion, while the pilocarpine is going to increase the drainage or increasing outflow of aqueous humor from Schellmann's channel. Through what? Through contraction of the ciliary muscle and through contraction of the constrictor muscle. It has other clinical indication. For example, it's also present as a mouth spray in the treatment of xerostomia or dry mouth. Betanicol, also it is selective muscarinic agonist, resists the action of choline esterase, can be used in the treatment of bladder atony or paralysis of the ileum, especially after operation. So these are the direct acting cholinergic agonists. What about the indirect acting? As I mentioned, they do not act directly on the receptor, but it will cause, or they cause, non-specific cholinergic stimulation. How? We have two mechanisms. The most important to us, through inhibition of choline esterase enzyme, either reversibly or irreversibly. And we have also other mechanisms. For example, we have a special or kind of spider, it's called black widow spider, that induce or stimulate release of acetylcholine and cause excessive stimulation of the parasympathetic and might be fatal and causing death of the patient. But the most important to us are the inhibitor of choline esterase enzyme. The inhibition of choline esterase enzyme could be reversible or irreversible. In the reversible inhibitor of the enzyme, we have physostigmine, neostigmine, pyridostigmine. Physostigmine is also lipid soluble, while neostigmine and pyridostigmine are polar or water soluble. They can be used in the treatment of GI atony, bladder atony, treatment of glaucoma, myasthenia gravis, and atropine poisoning. What's myasthenia gravis? It is one of the autoimmune disorder in which the antibody will form against the nicotinic receptor at the neuromuscular junction. So causing what? Causing weakness of the skeletal muscle. These drugs, especially neostigmine and pyridostigmine, used in the treatment of such condition. Hydrophonium, it is another indirect acting reversible blocker of choline esterase enzyme. It is mainly used to diagnose myasthenia gravis. Why? Because it has very short duration of action. Donepezil, rivastigmine, and galantamine, these three are used to slow the progression of Alzheimer's disease, not a treatment, just slowing down the progression of the disease. What's Alzheimer's disease? It is one of the neurodegenerative disorders characterized by loss of cognitive function, dementia, due to what? Due to degeneration of the cholinergic neuron in the brain. What about the irreversible inhibitor of the enzyme? We have drugs like icothiopate. It's present as an eye ointment, can be used in the treatment of glaucoma. It has a very long duration of action. The half-life is about 100 hours. We have insecticide or organophosphate insecticide like malathion, parathion. The important about this insecticide or organophosphate is poisoning. You should know everything about the organophosphate. Why? Because poisoning can easily occur. It's present almost in every home. So poisoning occur might be accidentally, especially by children, or as a suicidal attempt by young adult. It is lipid soluble. It can be absorbed even from an intact skin, even when we are using the insecticide as a spray. And it will cause overstimulation of the parasympathetic and causing death to the patient. The treatment or the antidote is atropine. In the irreversible one, we have also nerve gases, for example, sarin. This has been used during the chemical attack in Halabja, which caused stimulation of the parasympathetic and caused so many deaths. Okay. The last group of drugs that affect the autonomic nervous system is the parasympatholytic. So we are going to block the parasympathetic nervous system, or also called cholinergic antagonist, anticholinergic or parasympatholytic. It is classified according to their affinities to the receptor. So we have muscarinic blockers and nicotinic blockers. In the muscarinic blockers, we have atropine, scopolamine, ipratropium, tiotropium, cyclopentolate, tropicamide. In the nicotinic blocker, especially the nicotinic receptor at the neuromuscular junction, for example, we have a curare-like drug. These group of drug or curare-like drug are mainly used as a muscle relaxant during operation. It will induce complete muscle relaxation during surgery. How? By producing paralysis of the skeletal muscle. Regarding the anti-muscarinic, for example, atropine is the prototype of anti-muscarinic agent. It is derived from Atropa belladonna. It is lipid soluble, distributed everywhere, absorbed well after oral administration, and it has so many actions. For example, it will, in the eye, it will produce mydriasis or dilatation of pupil. In the CNS, it will cause, depend on the dose. Low dose causes sedation, high dose causes excitation. In the heart, it will increase the rate. In the respiratory, it will induce bronchodilation and decrease secretion. In the GIT, it will decrease peristalsis. And also, in addition to all of these, it is going to decrease the sweating. So the anti-muscarinic, for example, atropine, block the muscarinic receptor, causing inhibition of all muscarinic function. In addition to that, it is also going to block few exceptional sympathetic neurons that are cholinergic, especially sweat gland. So the secretory glands are highly sensitive to atropine, while the smooth muscle and heart are intermediate in their responsiveness. Atropine has so many clinical indications, but because of the long duration of action and possible side effect, the synthetic derivative of atropine nowadays is present with so many clinical indications. For example, In the eye, we have tropicamide cyclopentolate. Both of them are atropine derivative. They are going to induce dilatation of pupil before what? Before ophthalmological examination. Also, they are going to induce cycloplasia. We mean by cycloplasia, the patient become unable to focus for near vision. In the CNS, for example, benzotropine, another atropine derivative used to treat Parkinson's disease. What's Parkinson's disease? Another neurodegenerative disorder characterized by what or occur due to degeneration of the dopaminergic neuron. Scopolamine, it is another anti-muscarinic agent used to prevent motion sickness. In addition to that, also it is given before operation to induce or to decrease secretion. In addition to it is anti-secretory, it will also bring about amnesia. In the respiratory, we have ipratropium, tiotropium. Both of them are atropine derivative. They are going to induce bronchodilation. They are the drug of choice in the treatment of COPD and asthma, especially in patients with cardiac problem, because they are going to induce bronchodilation and decreasing respiratory secretion. In the GIT, we have hyoscine that decrease the cramp, pyrenzepine decrease acid secretion. In the genitourinary system, we have oxybutynin to treat cystitis or bladder spasm. So these are the clinical indication of synthetic derivative of atropine. Lastly, we have also drugs that act centrally to block the cholinergic system. For example, we have hemicolinium that inhibit the transport of choline and synthesis of acetylcholine. We have visamicol that decrease the storage of acetylcholine. We have botulinum toxin that inhibit or prevent the release of acetylcholine into the synaptic space and causing paralysis. These are centrally acting anticholinergic drugs. By this, we have done with the 4 groups of drugs that affect the autonomic nervous system. We have something called receptor regulation in the autonomic application. What we mean by receptor regulation? When we are about to block, for example, the adrenergic receptor. So when we block these adrenergic receptor, there will be an increase in the amount of receptor. Why this biological response occurs due to signal transduction in order to maintain homeostasis. This is called receptor upregulation. This is during blockage, and also it can be occurred during, for example, stimulation. What happens if we stimulate the receptor? The biological response is going to decrease the amount of receptor. This is called receptor down regulation. Why this is important? It is important clinically. For example, if we are going to block the adrenergic receptor, for example, for a long period, using metoprolol to block the beta receptor for more than 2 weeks. What happens if we suddenly stop the drug? There will be so many adrenergic receptor or beta receptor available and might cause overstimulation and might cause complication. This is the receptor regulation of the autonomic nervous system. And that's it, and thank you.